The AICD or ICD is an important tool for patients who have survived sudden cardiac arrest, have spontaneous sustained ventricular tachycardia, and are at high risk for life-threatening dysrhythmias secondary to end-stage heart failure. The use or invention of the ICD has significantly decreased mortality and morbidity in these patients who suffer from these conditions. The ICD or AICD consists of a lead system that's placed via the subclavian vein through the endocardium to the right ventricle. The battery-powered pulse generator is implanted subcutaneously over the pectoral muscle on the patient's non-dominant arm or side. The pulse generator is similar in size to a pacemaker, and it's usually a single lead system, like I mentioned above, where it terminates just into the right ventricle. The system can sense changes in the patient's heart rate and rhythm, and if they identify a lethal dysrhythmia, they're going to deliver a 25 joule or less shock to the heart. If the first shock is unsuccessful, the device will recycle and will continue to deliver shocks. This is just a picture of a Medtronic AICD. This is the company that typically makes a lot of the AICDs and pacemakers that you'll see. In addition to defibrillation capabilities, the ICD or AICD are also equipped to protect us in the event that we have tachycardias or bradycardias. The device is going to use algorithms that detect dysrhythmias, and they're going to determine the appropriate response. They can overdrive pace these tachycardias to terminate the rhythm. That way they don't have to shock the patient. They can also provide backup pacing when the heart rate gets too low. Pre-procedure and post-procedure care of the patient undergoing placement of an AICD or ICD is going to be similar in care to that of a patient undergoing a permanent pacemaker implantation. And we're going to talk about that in a couple slides. With this, the patient's going to experience a various array of emotions. There's going to be fear of body image changes. There's also going to be a fear of recurrent dysrhythmias because they're going to worry about the pain that occurs with an ICD discharge. And they're going to have a lot of anxiety about going home with one. So we're going to encourage our patients and their caregivers to participate in local support or online ICD support groups. So it's important that patients and caregivers adhere to the patient teaching for AICD or ICD placement. So you want to make sure that these patients follow up with their cardiologist or clinic for routine checks or interrogation of the functions of the AICD to make sure it's working properly and also to kind of investigate how it's been operating and what it's been doing for the patient. The patient needs to report any signs or symptoms of infection at the incision site, such as fever, redness. And the patient is typically asked to keep the incision dry for 4 days. The patient is also going to be instructed to avoid lifting the arm on the side of AICD or pacemaker placement until they're told they can. We're going to discuss resuming sexual activity with the cardiologist. And usually it's okay to resume activity once the incision is healed. They're going to avoid driving until cleared by the cardiologist. And this decision is going to be based on the ongoing presence of dysrhythmias, the frequency of firing of the ICD, their overall health, and state laws. We're going to ask the patient to avoid direct blows to the ICD site. And the patient needs to avoid large magnets and strong electromagnetic fields, such as with an MRI. And these patients should not have MRIs unless the ICD is approved as MRI safe. and there is a protocol in place at the facility for patients who have AICDs. We also need to make sure that we talk to them about air travel, that air travel is not restricted. They just need to make sure that they inform airport security of the presence of the AICD because it may go off under the metal detector. If a handheld screening wand is used, it should not be placed directly over the patient's AICD. Manufacturer information may vary regarding the effects of metal detectors on the function of the AICD. Patients should avoid standing near anti-theft devices in doorways of stores or public buildings. They need to walk through them at a normal pace. Patients also need to be instructed that if the AICD or ICD fires, they need to call their cardiologist immediately or get to the closest ER. If the pacemaker fires and the patient feels sick, they need to contact EMS or call 911 immediately. And they also need to go to the ER if it fires more than once. These patients are going to need to wear a medic alert ID or bracelet at all times. They need to carry the card and a current list of their medications with them at all times. And their caregiver and family members need to learn CPR. So artificial cardiac pacemakers is an electronic device that's used to pace the heart when the normal conduction pathway is damaged. The basic pacing circuit consists of a power source, a generator, just like we talked about with the AICD, that has a programmable circuitry, and that's going to have one or more pacing leads to the myocardium. The electrical signal travels from this generator through leads to the wall of the myocardium. When electrical signal is stimulated to the myocardium, and if the myocardium captures this impulse, it's going to stimulate a contraction. Current pacemakers, similar to AICDs, are very small, sophisticated, and they work physiologically well with the patient's heart, which allows it to have a coordinated, effective cardiac output. They can pace in the atrium, they can pace in the ventricles, or they can pace in both at the same time. Most pacemakers are demand, and what this means is that they sense the patient's electrical activity or their intrinsic or natural activity, and it's going to fire only when the heart rate or the patient's heart rate drops below the preset rate. And usually that preset rate is 60. Demand pacemakers have two distinct features. It can sense and it can inhibit the pacemaker when the heart rate is adequate. So if the patient's intrinsic heart rate is above 60, the pacemaker is not going to send an impulse. A pacing device that triggers the pacemaker when no QRS complex occurs within a preset time period. So all that means is that if the patient's intrinsic heart rate is above 60, it won't fire, but it's also going to sense if the patient's heart rate drops below 60, or if they don't see any impulses within a certain amount of time, it's going to trigger the pacemaker to send an impulse. This picture is just an example of ventricular capture or depolarization secondary to a signal of the pacemaker from the lead to the right ventricle. So the arrow shows what's known as a pacemaker spike, which you will see on the ECG. And if the patient's myocardium accepts that electrical impulse from the pacemaker, it's going to generate a complex right behind the spike. So what we're looking at here right now is a pacemaker spike in the ventricles that has initiated an impulse, and the ventricles have received that impulse and have contracted. And so we see that widened QRS impulse or electrical impulse. A permanent pacemaker is implanted totally within the body, and the power source is placed subcutaneous, usually over the pectoral muscle on the patient's non-dominant side. The pacing leads are placed intravenously to the right atrium, and either one or more both ventricles are attached to the power source. So you can have a single lead or a dual lead. This graphic displays a dual chamber rate responsive pacemaker from Medtronic. Pacing leads in both the atrium and the ventricle enable a dual chamber pacemaker to sense and pace in both heart chambers, which means it can pace and it can initiate an impulse that the myocardium can accept, and it will contract and it will show an impulse. And it also can sense the patient's intrinsic or natural impulses and contractions so that it doesn't have to pace. Permanent pacemakers are inserted to treat patients with chronic heart problems in which the heart beats too slow to meet the body's demands. So in a complete heart block, a complete AV heart block. Some of our patients who have a very slow atrial fibrillation, patients who have severe heart failure, and if they have significant bundle branch blocks, where there is a conduction delay down the right and left bundle branch. So cardiac resynchronization therapy is a pacing technique that resynchronizes the cardiac cycle by pacing both ventricles at the same time. It's called biventricular pacing. This is going to promote improvement in ventricle function in patients who have end-stage heart failure. So most of these heart failure patients have interventricular conduction delays, which causes abnormal ventricular contractions. It causes dyssynchrony between the right and left ventricles that results in reduced systolic function, pump inefficiency, and it's going to reduce cardiac output and worsen their heart failure. For patients with severe left ventricular dysfunction, cardiac resynchronization therapy is combined with an implantable AICD for maximum therapy. So it's going to let the right and left ventricles work together in a coordinated effort to maximize cardiac output. So a temporary pacemaker, we just talked about a permanent one, is one that has a power source outside of the body. There are three types of temporary pacemakers. You have a transvenous, an epicardial, and a transcutaneous. So a transvenous pacemaker consists of leads that are threaded transvenously to the right atrium, to the right ventricle, and it's going to be attached to an external power source. Most temporary transvenous pacemakers are inserted in the ER or in the ICU in emergent situations. They're going to usually provide a bridge to insertion of a permanent pacemaker or until the underlying cause of the dysrhythmia is resolved. So a lot of times if your patient's digoxin toxicity, or if they have an electrolyte imbalance or disturbance that has caused a significant heart block, a complete heart block, we'll have a patient have a transvenous pacemaker temporarily until the rhythm resolves, and then it can be pulled out. Epicardial pacing involves attaching an atrial and ventricular pacing lead to the epicardium during heart surgery. These leads are then going to be passed through the chest wall by the surgeon and attached to an external power source. They're usually placed prophylactically during surgery because these patients after cardiac surgery, coronary artery bypass, are at increased risk for arrhythmias in the early postoperative period. So after the patient has been deemed stable, a couple 2 to 3 days after surgery, as long as they don't have any persisting arrhythmias or dysrhythmias, nurses who are confident, who have been signed off, can either pull or cut these epicardial wires. These are just examples of the temporary pacemakers that are attached to a programmable external power source. So a transcutaneous pacemaker is going to be used to provide adequate heart rate and rhythm to patients in an emergent situation. So the placement of a transcutaneous pacemaker is non-invasive and it's temporary, usually a bridge to a transvenous or until a definitive therapy is available. The transcutaneous pacer consists of a power source and a rate and voltage control device, usually the defibrillator that we use on the crash cart. And it's going to be attached to two large electrode pads, the same one that we use to defibrillate with. We're going to position one pad on the anterior portion of the chest. Usually where the V4 lead is, we'll replace it anteriorly in a precordial position. And then we're going to put the other one on the back between the spine and the left scapula. We're always going to use the lowest amount of energy that's going to result in a myocardium contraction or capture to minimize patient discomfort, because we're giving this patient energy right through their chest, right through their muscle, and it hurts. These patients need to be adequately sedated, given plenty of pain medication. And again, transcutaneous pacing is temporary. Before initiating the transcutaneous pacing, we need to explain to the patient what's going on, what we're going to do. And we're going to explain that the muscle contractions created by the pacemaker can be uncomfortable. We're going to reassure the patient that it's temporary and that it's going to be replaced with a transvenous as soon as possible. And like I said, whenever possible, we're going to make sure that we give these patients pain medication and sedation. So typically when you initiate transcutaneous pacing from the defibrillator machine that's on the crash cart, we're going to usually set the rate to 60 or whatever the physician determines is appropriate for the patient. And we're going to set the current or the amount of outflow that is used to initiate an impulse from the patient. And we're usually going to do the lowest amount that's required because, like we said, it's painful. So the transcutaneous pacing, or TCB, consists of a power source and a rate and voltage control device that attaches to two electrode pads, like we said. We're going to position the one pad, again, like I said, on the anterior part of the chest and the other on the back. And these pads can be used for both pacing and defibrillation. Patients with temporary or permanent pacemakers will be continuously ECG monitored to evaluate the status of the patient's pacemaker to make sure it's working. Pacemaker malfunction primarily involves a failure to sense or a failure to capture. And what that means is the failure to sense occurs when the pacemaker fails to recognize when the patient's own natural intrinsic atrial or ventricular activity occurs, and so it's going to fire inappropriately, even though the patient's heart is doing the work. And the problem with this is that it can result in the pacemaker firing during an excitable period in the cardiac cycle and result in ventricular tachycardia. The failure to sense is caused by pacemaker lead damage, battery failure, or sometimes the programming is set incorrectly, or maybe an electrode has been dislodged. Failure to capture occurs when the electrical charge to the myocardium is not enough to produce a contraction. So this can result in asystole or significant bradycardia. So this can happen if the pacemaker lead is damaged, dislodged, or there's battery failure. So complications of permanent pacemaker insertion is infection, hematomal formation, pneumothorax. So just like when we put a central line or a PICC line in, again, failing to sense, failing to capture, and we can perforate the septum when the lead is floated in. Several measures can prevent and assess for complications. These include giving prophylactic IV antibiotics before pacemaker insertion. We're going to get a chest x-ray after placement to assess for pneumothorax or hemothorax or hematomal formation. And we're also going to do it to assess for lead placement to make sure the pacemaker lead is where it needs to be. We're going to continuously monitor these patients' ECG rhythm and rate. After the pacemaker has been inserted, the patient can get out of bed once they're stable. They need to have limited range of motion to that affected arm, and it's because we don't want them to dislodge the newly implanted pacing leads. We're going to observe the site for signs of bleeding, infection, and most patients are going to be just kept overnight and discharged the next day. And then we're going to provide patient teaching that's very much in line with AICD. Again, we want to make sure that these patients follow up with the appropriate person, whether it's their cardiologist or whether it's the pacemaker clinic. We want to make sure that things are working well, that it's programmed correctly. We want the patient to report any signs of infection to the incision area, to the site. These patients need to make sure that they avoid lifting the arm where the pacemaker has been placed until approved by your cardiologist. No direct blows. They need to avoid close proximity to high output electrical generators. They should not have MRIs unless their pacemaker has been approved as MRI safe. Microwaves are safe to use and do not interfere with pacemaker function. Just like we said before with AICDs, they need to avoid standing near anti-theft devices. They should just walk through them at normal pace. Air travel is not restricted. They just need to inform airport security that they have a pacemaker and that they could set off the metal detector. They should not be, the handheld device should not be used because it can alter pacemaker programming. And the patients should be taught how to monitor their pulse rate and rhythm and inform the cardiologist if it drops below the predetermined rate, which is usually 60. They should make sure that they have a medic alert ID, and they should carry their pacemaker information card and their drug list with them at all times. The 12-lead ECG is a key diagnostic tool we know to evaluate patients who present with ACS. So some of these ECG changes are going to be or represent ischemia, injury, or infarction to the myocardial cells or myocardium. We need to remember the leads that are facing the area of involvement are demonstrating the ECG changes. Typical ECG changes that are seen in myocardial ischemia include ST segment depression and or T-wave inversion. So ST segment depression is significant if it's at least 1 millimeter below the isoelectric line. Depression in the ST segment or T wave inversion occurs in response to the imbalance between supply and demand to the myocardium, and it's going to cause an electrical disturbance to the myocardial cells. Once treated or once blood flow is restored, these ECG changes are just temporary. They're going to resolve, and it's going to return to their patient's baseline. The isoelectric line is flat and represents those normal times in the cycle when the ECG is not recording any electrical activity. And it's also after the T wave and up until the next P wave of the subsequent impulse, because it's when the cells are polarized. These times are as follows. It's from the end of the P wave to the start of the QRS complex, the entire ST segment, and from the end of the T wave to the start of the next P wave. Myocardial injury represents a worsening stage of ischemia, usually greater than 20 minutes, that is potentially reversible but may evolve to a myocardial infarction. So we know the typical ECG changes seen during injury is ST segment elevation. ST segment elevation is significant if it's greater than 1 millimeter above the isoelectric line in 2 different leads. If treatment is prompt and effective, it's possible to restore oxygen and avoid limit an infarction. The absence of serum cardiobiomarkers will confirm this. Note the dramatic ST segment elevation associated with myocardial injury. A physiologic Q wave is the first negative deflection following the P wave. It is normally very short and narrow and noted in this ECG tracing on the slide. So it's not apparent in every lead, but in some leads it's normal. In addition to ST segment elevation, a pathological Q wave may be seen on the ECG in patients with an infarction. A pathological Q wave develops during an MI, is wide, greater than 0.03 seconds, and is going to be deep, which is greater than 25% of the height of the subsequent R wave. This is referred to as a Q wave MI. The pathologic Q wave may be present on the ECG indefinitely and the associated lead. Note on this slide the deep, wide Q wave, which is considered pathologic, indicating the presence of a myocardial infarction. T wave inversion related to MI occurs within hours following the event and may persist for months. The ECG changes seen in injury and MI reflect electrical disturbances in the myocardial cells caused by a prolonged lack of blood and oxygen leading to necrosis. The ECG findings on a 12 lead with anterior lateral wall myocardial infarction. Normally leads 1, L, V1 to V3 have positive R waves. Note the pathological Q waves in these leads and the ST segment elevation in leads VT, V2 to V5.